Welcome, everybody. Welcome to our February Grand Rounds. I'm Howard Chansky. I am the chair of the Department of Orthopaedics and Sports Medicine. We're very fortunate this morning to have Kara Mitchell, who's a clinical associate professor in the Department of Medicine, the Division of General Internal Medicine, who's going to work with Dr. Paul Manner, professor of orthopedics and sports medicine, as well as Jake Wilkerson, one of our R4s in the department. And they are going to be talking about preoperative optimization in total joint surgery. Anybody that's even remotely familiar with total joint surgery is probably familiar with the pressures that we face to take care of sicker and older patients, to get them out of the hospital expeditiously, including now national move towards outpatient total joint surgery. And this is tied in with the financial pressures that we have with reimbursements to hospitals and physicians continuing to gradually decline for total joint patients. With that, I'm going to introduce Dr. Wilkerson to begin Grand Rounds. Thank you.
Thank you, Dr. Chansky. Can everyone hear me okay?
Yeah.
So Dr. Manner, Dr. Mitchell, and I chose this topic because we thought it was broadly applicable to really anyone doing elective surgery and across the board for every subspecialty in orthopedics. The title of my topic is Preoperative Patient Optimization in Total Joint Arthroplasty. I have no disclosures. Studying this topic reminded me of the portion of the Hippocratic Oath, primum non nocere, which means to first do no harm. And I think that's really critical for discussion of this topic because whenever we think about signing a patient up for elective surgery of any kind, we need to consider the morbidity and mortality of the surgery that we're offering and what that can mean for a patient. The scope of this talk is to talk about implications of poor outcomes, identify patients at risk for poor outcomes, including mortality, and to strategize for improvement. Why this matters? This matters for our patients and their outcomes. It matters for the cost and the national healthcare burden in the United States. And ultimately, this is really our responsibility. We're the ones seeing these patients in clinic, talking with them about surgery and initially assessing them for risk. I find myself in clinic looking at an epic snapshot sometimes and trying to decide if a patient is appropriate for surgery. And I don't know that I honestly put as much thought into it as I will after researching this topic a little bit more. So I think it's useful. As Dr. Chansky mentioned, our patient population is able to live longer and healthier due to modern healthcare. But as a result, they are becoming more medically complex as time goes on. This is a table taken from a study looking at Medicare beneficiaries receiving primary total hip arthroplasty over about 2 decades. And you can see in the highlighted red portion that the number of comorbidities are increasing every year in the patients that are undergoing total joint arthroplasty. As our payers continue to investigate quality metrics, they are increasingly looking at 30 and 90-day readmissions as a cause for increased cost, especially after total joint arthroplasty, which has become such a highly performed procedure. And you can see from this article out of Core in 2017, this table shows that of the complications, medical and procedural, that occur after total joint arthroplasty, infection is, as we know, very devastating for patient outcomes and very costly to our healthcare system. It's also one of the most common reasons for readmission. And this is really why a lot of the literature for preoperative optimization focuses on trying to limit the trying to modify risk factors to limit infections in this patient population. There was another study looking at risk factors modifiable that are associated with an increased 90-day readmission rate in total joint arthroplasty patients. And all of these risk factors were found to be highly significant in patients getting readmitted to the hospital after joint replacement surgery. And they were uncontrolled diabetes, obesity, cardiovascular comorbidities, nicotine, drug and alcohol abuse, physical deconditioning, fall risk, and malnutrition. Today, I really wanted to focus on those that we maybe perhaps focus on the most every day, just because of the prevalence of these issues in uncontrolled diabetes, obesity, and nicotine use. And I also wanted to just briefly touch on cardiovascular comorbidities, because that's really what causes mortality after total joint arthroplasty, and anything we can do to limit mortality after an elective surgery absolutely is important. Obesity has been extensively studied as causing increased risk for a multitude of complications, including wound complications, suboptimal component positioning because of body habitus, prosthetic joint infection, revision surgery, and hospital readmission. It's also interestingly been shown to cause poor patient-reported outcomes. So these patients are not as pleased with the surgery that they received. Preoperative strategies, I think it's easy to see a patient in clinic with a very high BMI and kind of brush them off and just be like, well, you're not a candidate for an elective surgery. We'll see you back when you get things under control. That's really a missed opportunity, I think. And you can establish, and engage your patients with a weight loss plan, and whether that means referral to a weight loss clinic, explaining to them that a combination of diet and exercise results in greater weight loss than either in isolation. That may seem obvious, but I think that some patients just don't really know where to start, because it seems like such an overwhelming affliction for so many people. And there's a picture of Tony Little. Bariatric surgery has been extensively studied in the joint literature because it was initially thought to be an excellent solution for obesity and total joint arthroplasty patients. Early studies showed a decreased complication rate, but more recent studies with the table included below have shown a higher post-op readmission and revision rate in bariatric surgery patients. And the study that I'm showing and referencing, it looked at a cohort of patients who had undergone bariatric surgery, those who had a high BMI and a low BMI, otherwise considered obese and non-obese, who underwent total joint arthroplasty, and looked at their readmission, complication, revision, and PGI rates, prosthetic joint infection rates, at 1 and 5 years, and found that the bariatric surgery group actually had a higher rate of reoperation and revision than even the higher BMI group and the lower BMI group. This is theorized to potentially be from malnutrition in the short-term period after bariatric surgery, and potentially a limited change in body morphology after undergoing bariatric surgery. So I think the jury is really still out on whether bariatric surgery effectively reduces complication rates. Diabetes is another extensively studied topic in the total joint literature. The uncontrolled diabetes, and maybe more importantly, perioperative hyperglycemia, is linked to increased wound and systemic complications, venous thromboembolism, prosthetic joint infections, and is known to increase length of stay, hospital costs, and mortality in patients undergoing joint arthroplasty. Forgive the European units here, but I thought this was an interesting study that looked at the combination of perioperative hyperglycemia and obesity. And they stratified this based on body mass index, and found that if patients were morbidly obese and had an elevated preoperative blood glucose, then they were at a 7-fold risk for prosthetic joint infection over the course of 1 year. And I thought that was pretty scary. Whenever we talk about diabetes, I think we're most used to paying attention to the hemoglobin A1C, because we immediately search for it in their records and try to find the level that they were most recently at. unfortunately, that may not be the most appropriate way to evaluate the patients who are undergoing joint arthroplasty, because it may not be the blood glucose control levels over the prior 2 to 3 months as represented by the hemoglobin A1C, but more the blood glucose control leading up to the actual surgery and in the post-operative period. And so the other issue with the hemoglobin A1C is also that some insurers will not cover a hemoglobin A1C in non-diabetics and without a random blood glucose. So what may be a reasonable approach is to obtain a random blood glucose in any patient that you're considering performing surgery on. And then if that is elevated, then you can obtain a hemoglobin A1C with an appropriate indication to establish a diagnosis of diabetes. Perioperative blood glucose is thought to be the most important risk factor for development of complications associated with diabetes, but that also applies to patients who are non-diabetic as well. Fructosamine has been kind of buzzed about in the recent literature for perhaps being a better marker and predictor of complications associated with hyperglycemia in total joint arthroplasty patients. And largely that's because fructosamine is a marker that reflects blood glucose control over the prior couple of weeks as opposed to the prior couple of months. And so it may give a better representation of how patients have been doing most recently. This was an interesting study, the one the Insol Society Award 2 years ago in the Bone and Joint Journal. And I thought that this table was particularly interesting because they looked at prosthetic joint infection, wound complication, readmission, reoperation, and mortality, and looked at the predictive value of fructosamine and then hemoglobin A1C at 2 different threshold values, 7.0% and 7.5%. And they found that patients who had high fructosamine levels were much more likely to develop prosthetic joint infection, readmission, and reoperation. And the highlighted portion in red shows that in patients who had a high fructosamine level and a low hemoglobin A1C, they were at very high risk for developing these complications. And so it shows the predictive value yielded by fructosamine as opposed to the hemoglobin A1C threshold values. Preoperative strategies in patients with diabetes. Again, as with obesity, I think it's important to talk with patients, explain to them why this matters for their surgery. I think that they are often inundated with, get your blood glucose under control, or perhaps being told that they're just not a candidate. But establishing a line of communication with their providers and scheduling a follow-up with that patient to make sure that you're touching base with them and their other providers to make sure that they're getting better control of their diabetes, I think is critical. And as with obesity, you can refer them to physical therapy to look at alternative exercises because arthritic patients are painful to mobilize. And so if you tell an obese and diabetic patient to exercise, I think that's pretty easy from our standpoint, but we don't realize how often that can be very painful for these patients. And so referring them to physical therapy, I think, is useful. Strategies for diabetics more in the perioperative period are holding short-acting insulin, having long-acting insulin the morning of surgery, resuming oral medications on post-operative day 1. Notably, for some of the oral medications, we should be cautious at looking at the BMP on post-operative day 1 to make sure that their renal function is appropriate, because medications such as metformin should maybe not be resumed if they're demonstrating any renal insufficiency. We should check post-operative day 1 blood glucose, even in non-diabetics, and initiate sliding scale insulin if it's over 200 milligrams per deciliter, because that, as I mentioned before, can decrease risk for complications associated with hyperglycemia, even in patients who had not prior been diagnosed with diabetes. Nicotine use is very prevalent in the United States and remains widespread. The most recent CDC data demonstrates that nearly 21% of US adults use some form of nicotine, and that smokers and former smokers are at increased risk for reoperation, revision, implant loosening, deep infection, and mortality. Many of our patients who have used tobacco or nicotine products have been using them for the majority of their lives. And so I think that it's easy for them to be disheartened about the prospect of quitting, because they may not realize the benefits that they can appreciate and experience at a short term after quitting. The respiratory and anesthesiology literature shows that after 4 to 6 weeks of cessation, metabolic and immune functions begin to normalize. And there have been multiple studies looking at the effect of interventions on cessation with risk reduction in terms of complications. And they found that interventions initiated at less than 4 weeks, or excuse me, as late as 4 weeks before elective surgery, can reduce risk for postoperative complications, even though patients who are former smokers are at some permanent increased risk for complications. So what works? Again, I think it's easy for providers to say, well, you really need to quit smoking or using nicotine. And I think it's really, really challenging for a lot of patients. And so providing them with options is really important. Options include behavioral therapy, nicotine replacement therapy, acupuncture, pharmacologic interventions such as varenicline, and hypnosis. This was a Cochrane review meta-analysis of 13 trials enrolling over 2,000, or looking at over 2,000 participants, and they found that multi-session face-to-face counseling once a week and offering nicotine replacement therapy at least 4 weeks prior to surgery cut postoperative complications in half. And so I think that that's important to tell patients, because they can make a sizable change in their risk reduction and risk profile by participating in counseling, which they may not see as having any benefit, but talking about them with this, I think, might change some people's minds and motivate them to be more engaged. One other thing that I wanted to talk about was mortality after total joint replacement. So the most common cause of death after joint replacement surgery is cardiovascular, whether that be acute coronary syndrome, pulmonary embolism, cardiac arrest, or fatal tachyarrhythmia. The rate of these is still relatively low. I think that the overall rate from the literature that I looked up was 0.03% of patients will have a major cardiovascular event after undergoing total joint arthroplasty. That being said, anything we can do to limit mortality after an elective surgery is critical, especially with the numbers of patients that are undergoing these procedures. And so there have been a multitude of studies looking at trying to evaluate preoperatively which patients are at risk for developing major cardiac complications and mortality. They have, there was a study out of JBJS in 2014 that looked at a large number of patients from the NISQIP database and found that patients with age over 80, hypertension treated with medication, and a history of cardiac disease were significantly predictive of developing a major cardiac complication. When I look at these risk factors, age over 80 and hypertension treated with medication, I mean, that is a lot of patients who are undergoing total joint arthroplasty. And that maybe would not have pricked up my ears to paying attention to that as cardiac disease may have. But I think that patients with a combination of these risk factors should seriously be considered for a cardiology referral and at least a medicine preoperative referral to really evaluate their risk profile and to see if there are any interventions that can limit their mortality after the surgery. Summary for my portion of the talk. So optimization of our patients decreases cost and decreases our national healthcare burden and improves patient outcomes, more importantly. We can empower patients with tools to improve their health prior to surgery. And overall, we should have a low threshold for referral for preoperative medicine and cardiology consult services. And again, whenever we're thinking about signing these patients up for clinic or for the operating room in clinic, it's really important to take a deep dive into their chart, because we are the first line of detecting these potential risk factors that may be optimized by either our or the medicine team's interventions. Thank you so much. And now I'll transition the talk over to Dr. Mitchell for her portion. Thank you very much.
Thanks, Dr. Wilkerson. That was a really, really nice summary of metabolic issues that lead to surgical risk. Let me share my screen. Can everyone see that? Good morning. Thank you for asking me to join you today. I know many of you from the UW Montlake Medicine Consult Clinic, where I worked from 2005 to 2018. These last 2 years, I've been up here at UW Northwest, and my clinic is kind of between the operating room and the waiting area. And I look forward to growing the consult service as surgical services continue to expand here. Move forward. There we go. I have no disclosures, except to say that I do medicine consult for a living. So I may be a little biased toward thinking that these issues are important. There are different styles of collaborative care, consultation, and co-management. But regardless of who's running the show, our goals are similar. We want to first help to recognize factors that put patients at risk for complications of surgery. We want to modify or improve these risk factors to prevent complications. And we want to help pre-op and post-op to try to mitigate any complications that do occur despite our best efforts. This study is how I justify my existence. So many hospitals have anesthesia pre-op clinics that address issues such as high-risk airways, cardiac risk factors, things that increase the risk for intraoperative complications. This study of a little over 5,000 VA patients looked at the value that might be added by a hospitalist evaluation, and they found some benefits. So without diminishing the value of an anesthesia pre-op, adding a medicine pre-op for some high-risk patients, those with an ASA score of 3 or higher, reduced hospital length of stay. It reduced inpatient mortality, because what do patients die from? Heart attacks, arrhythmia, PE, things that Jake mentioned. Many of those things happen after surgery. And then we believe too that reduction in same-day cancellations is a major goal. So the conclusion of the study was that a structured medical pre-op evaluation may benefit medically complex patients. And this is why I triage patients, because they need to be pretty sick to show a benefit to a medicine consult. Not everybody needs the fine-tooth comb that you've seen in my notes. So that's who I am and what I do. Let's set some goals for the rest of today's talk. I would like to identify some at-risk patients, identify how we can find those patients prior to surgery. I like to see them at least 3 or 4 weeks at a minimum, so that there's time to try to modify some risk factors. And I think up to 6 to 12 weeks before something like an elective arthroplasty is good, because it allows referrals and more advanced testing, such as a sleep study. But we have to be careful, because while we want to see them with enough time to optimize the medical issues, we still want the medical evaluation to be valid at the time of surgery. And many of the patients who come through my clinic are ill enough that things will change after I see them. So, and then a second goal would be, of this talk for me today, would be to convince you that instead of using the phrase cleared for surgery, which may inadvertently imply no risk or minimal risk, I like to say medically optimized, or benefits of surgery outweigh the risks. And that's just because, almost by definition, patients who are sick enough to come to see me can never really be cleared for surgery. We just want to make surgery as safe as possible for them. And then my third goal would be to help you at least start to think about when to cancel surgery if patients can be further optimized. So this, in the end, will be a personal decision, because many of these risk factors don't have clear cutoffs. And then at the bottom of this slide, I've listed for you a handbook, which I contributed to. It was written by our Med Consult group. It's one of the only textbooks in the area of perioperative medicine consultation, and it's available for free via the Health Sciences Library. So it's a nice resource for residents who are thinking about risk stratifying patients, can turn to a specific chapter and at least get some initial guidance. All right, enough talk. Let's do a case. My first case is a 65-year-old man with rheumatoid arthritis and diabetes for whom you have performed several joint replacements over the years. He presents for a left hip replacement for avascular necrosis. He has rheumatoid arthritis for 35 years, treated with prednisone currently, and methotrexate and Humira. And he has diabetes diagnosed 7 years ago. And just 1 month ago, insulin was added. Current medications you see here: NPH insulin, metformin, prednisone, methotrexate, and adalimumab, which is Humira. His review of systems is negative except the arthritis, deformities, and he could recently walk a mile without chest pain or dyspnea. Vital signs are normal. His weight's 160 pounds. There are chronic changes of rheumatoid arthritis. His affect's a little flat, but otherwise the exam is pretty normal. The random glucose is 150 milligrams per deciliter, but the Chem7 is otherwise normal. And the hemoglobin A1C is 12.2. So here's my question for you, and I'd like everyone please to kind of mentally commit. Would you cancel this patient for the hemoglobin A1C of 12.2? And if you've mentally committed, I would like to submit that I would not necessarily cancel this patient's case. Note that the hemoglobin A1C of 12.2 and the blood glucose of 150 are discordant. This first study I want to submit to you is entitled Effective A1C and Glucose on Post-Operative Mortality in Non-Cardiac and Cardiac Surgeries. And this study showed that it is blood sugar at the time of surgery, not in the months preceding surgery, that impacts outcomes. And this makes perfect sense. Our own Patch Dellinger, who is double boarded in general surgery and infectious disease and recently retired from the UW, published a nice discussion of this 20 years ago, and it is still applicable today. He noted that hyperglycemia is a predictor of poor outcomes in diabetics and non-diabetics. So should we cancel for the A1C? Not necessarily, and it's because A1C, as Dr. Wilkerson started to tell us in his talk, is an estimate of glycemic control in the last 3 months. It is falsely high in people who have recently intensified therapy, like our patient. So imagine the lifespan of a red blood cell, it's about 3 months, which is why the A1C gives us an idea of glycemic control over the past 3 months. But what if control was really terrible at the beginning of those 3 months and really good at the end? Or on the other hand, imagine that you transfuse a patient with a non-diabetic's quote unquote sugar-free blood. Or what if the patient's red blood cells are living longer because of iron deficiency, or living shorter because of hemolysis or being lost through bleeding, and the bone marrow revving up new and kicking out new unglycosylated red blood cells. So the A1C has a lot of problems with it, and for all of these reasons is not a good predictor of post-op blood glucose. I'm not saying I don't use it, I'm just saying you have to really be careful. So no, I would not cancel this patient for his A1C, but I would cancel if his blood sugars were elevated. So I would ask him to bring a log, or I would check fructosamine, which is something else Dr. Wilkerson has already discussed. Fructosamine measures blood sugars over the past 1 to 3 weeks, average of about 2 weeks. It's a little cumbersome because it takes time to come back. But it's if you have someone you're considering canceling, this can be helpful to show that, yes, indeed, the glycemic control has improved in recent weeks. And then I would cancel this patient's surgery because his prednisone dose is greater than 10 milligrams, unless for some reason it can't be tapered. So of course, if the patient has giant cell arteritis and tapering prednisone would be life-threatening, I would not taper. But this patient's rheumatoid arthritis therapy is not optimized and can be optimized to try to lower the prednisone dose and reduce his risk for infection. This is a retrospective analysis of NISQIP data that used CPT codes to identify 403,000 total knee arthroplasty and total hip arthroplasty patients. So those ginormous numbers lead to very significant p-values. But you can see, as we all know, chronic corticosteroids increase the risk of all types of surgical infection. And this study from the medicine literature, the risk of glucocorticoids in patients with rheumatoid arthritis undergoing arthroplasty, looked at a cohort of 9,911 patients. They were all being treated with biologics, and some were on prednisone and some were not. And this study found that glucocorticoids were associated with a dose-dependent increase in post-op risk for prosthetic joint infection. And you can see from these confidence intervals that when people are on more than 10 milligrams, the risk is much higher. I have a couple of management tips similar to what Dr. Wilkerson shared, and I really want to particularly underline the newer medication, the gliflozins, SGLT2 inhibitors, like empagliflozin and canagliflozin. These medicines need to be held for 3 or 4 days before surgery, and the reason is that they cause euglycemic ketoacidosis. So people will have diabetic ketoacidosis, but their sugars will not be high, and it can be life-threatening if this is missed. So when people are going to fast for surgery, we hold these medicines. And then the other high yield tips are, we of course hold prandial insulin when folks are fasting, and they're oral and injectable medicines the morning of surgery. But we do not hold long-acting basal insulin. So just as Dr. Wilkerson said, we give half to 75% while fasting to match liver gluconeogenesis, which continues despite fasting. And I really hope, would love to see all of these patients in my clinic to help with these details. As human hunting and gathering techniques have changed over the years, so has our physique. So I didn't include a case today on obesity because Dr. Wilkerson already addressed the highlights and so clearly. And also because weight loss is typically a longer term process that I can't impact very well for pre-op clinic. But I use this slide to highlight that it is still very important. All right, let's pause and do a second case. This is what I really love to talk about, cardiopulmonary risk stratification, but unfortunately that's the topic subject for another day and an entire talk unto itself. So let's, this patient has some metabolic risk factors. So let's talk about this case. 65-year-old woman with coronary artery disease and emphysema. She presents for left knee replacement for osteoarthritis. She has coronary artery disease, status post-MI, and a drug-eluting stent 2 years ago. She's on aspirin, metoprolol, and atorvastatin, and she has COPD diagnosed 5 years ago, chronic morning cough, but no recent exacerbation. And this patient has a huge modifiable risk factor, which is also the driving cause of her heart and lung disease. It's that she has smoked a pack, 1 or 2 packs a day for 40 years. Her partner also smokes, which will make quitting more challenging, but certainly not impossible. She has no chest pain and dyspnea after a flight of stairs. This image is from the 2014 Surgeon General's report. The effects of smoking on the body are legion, as you all know very well, and many of them impact recovery from surgery. For patients, the risks that I typically call out, they almost always have lung cancer and emphysema on their minds, but for surgery, we want to think about the risk for pneumonia and bronchitis, myocardial infarction, stroke, venous thromboembolism, skin and soft tissue infection, which, as you saw from Dr. Wilkerson's slides, is very costly, and also wound healing problems and risk for hip fracture. The question, though, is, does smoking cessation lower these risks? And the answer is yes. Smoking, this is a study from the Journal of Orthopaedics, this just very recent, that showed smoking cessation correlates with a decrease in infection rates after joint arthroplasty. This was self-reported quitters. And there was a trend toward higher quit rates, shorter length of stay, and lower infection rates in those who actually attended a formal program. So when is the right time to quit? And the answer is the sooner the better. So in the first 48 to 72 hours after surgery, there is increased risk for clearance of secretions. Patients' paralyzed cilia start to beat, and secretions that had been previously trapped in the lungs come up. And so many have argued, and there's not great evidence one way or the other, that people shouldn't quit smoking 1 or 2 days before surgery because of those increased secretions. But again, as Dr. Wilkerson pointed out, as little as 2 to 4 weeks before surgery, those secretions start to go down, and there's an improvement in airway reactivity. And then at 4 to 6 weeks, immune and metabolic function begin to normalize. By 12 weeks, we kind of hit a plateau of the expected benefit. And so I really love to see these patients in clinic a couple months before surgery so I can be another voice speaking into their lives. There's no right way to quit. I've listed here some different strategies that are recommended by the American College of Surgery and many others. The most important thing though is, you'll see in this slide, is patient buy-in. So they need to pick a date, they need to commit and get rid of all of their supplies and buy substitute supplies such as sugarless gum or nicotine replacement. They need to practice telling their friends that they're not a smoker and involve family and friends to keep them accountable. And it's an individualized strategy. Sometimes it feels, I think, as a provider, a little overwhelming because we can't be there with the patient when these decisions are made. Do I pick up the cigarette again, or do I pick up do I start vaping again? But there is something we can do. This is from a study in 2019, looking at continine testing, which improves smoking cessation before joint arthroplasty. Anecdotally, patients often tell me that knowing they're going to be tested before surgery is extremely helpful in the short term. So I don't have data for the long term, but we do know that testing significantly improves self-reported quit rates. And it also helps you identify those people who sort of say they quit, but that really they didn't. Now the question is, what are we going to do with that information? Are we going to cancel surgery, or are we just going to counsel the patients about the risk and proceed? But I'm increasingly convinced that this kind of testing is helpful. This next slide is my attempt at a transition slide, to exercise the right side of my brain, which gets a little fatigued in the middle of a talk like this. My 10-year-old saw it, and luckily she took pity on me and made me a little better one. So I don't know what you think is better. I'm still a little emotionally attached to mine, but hers was not bad. All right, let's do a final case. This is regarding malnutrition, and is a patient I saw not long ago, a 32-year-old woman, pre-op for hip arthroplasty for avascular necrosis. She has alcoholic cirrhosis with jaundice, ascites, and known esophageal varices. And as importantly, or maybe more importantly, she has anorexia nervosa ever since the age of 17. Her typical weight is only 95 pounds, and her lowest weight was 75 pounds. She's been hospitalized multiple times, and her BMI in clinic today is only 14.7. We discussed hospitalization from clinic, and in the end didn't do that. But she was symptomatic with weakness, fatigue, cold intolerance, lightheadedness, and abdominal pain, all typical symptoms of severe malnutrition. Interestingly, her labs were not terrible, and this is probably due to the chronicity of her illness. Despite underlying cirrhosis and long-term chronic malnutrition, her albumin is 4.6. And I highlight that to remind all of us that an albumin is not a good predictor of nutritional status. It can rise or decrease with inflammation, right? So it's a negative acute phase reactant. When patients have infection or inflammation, it goes down, and it's not necessarily responsive to efforts to increase it. So this is from the SPEN guidelines on nutrition screening. When somebody is undergoing a moderate risk surgery, such as joint arthroplasty or other orthopedic surgeries, for the rest of the audience, consider these factors. So the adequacy of their diet, any recent unintentional weight loss, low BMI. The cutoff I use is less than 20.5, although there's variable cutoffs. Visible loss of muscle mass or fat, and hand grip strength is used in research, not so much clinically. You have to be a little careful too when you're seeing these patients, because when they weigh in, especially patients with chronic malnutrition, such as mine with anorexia nervosa, she had shoes on, she had keys and heavy things in her pockets, trying to sort of make it look like she weighed more than she did. These are some of the complications of malnutrition, both for surgery and just in general. So these patients are at risk for pericardial effusion, hypotension, heart failure, bradyarrhythmias, and sudden cardiac death, primarily related to electrolyte abnormalities. They have weakness all over, respiratory muscle weakness, and then just skeletal muscle weakness, putting them at risk for falls. They have GI dysmotility, usually are severely constipated, and also may have swallowing muscle weakness leading to an aspiration risk. And of course, they're at risk for infection and wound healing problems. And the intervention point that I'd like to make is that just a week of adequate nutrition can prepare the body for surgery. So we always try to use enteral nutrition because the cost is less. And also having those micronutrients in the gut helps maintain the integrity of the gut mucosal lining and prevent infection. And I'm not a nutritionist, but these are the cutoffs goals for calories and protein. So in this case with treatment, this patient was able to quit drinking. Many of her markers of cirrhosis improved. So a large portion of her symptoms were related to active alcoholic hepatitis. And when she quit drinking, she improved dramatically and her BMI got up to 16.5. Now notice that that's still a really low BMI, and she was still at a significantly increased risk for complications of surgery, especially with her underlying liver disease. But the prognosis of anorexia is terrible. It's really hard to get patients to gain weight because of a dysmorphic body image. So even though they appear thin to us and we know that they're malnourished, they don't, it's hard to help them see that that's the case because of their underlying illness. And so we have to have reasonable goals that take into account what is a reasonable thing we could achieve for this particular patient. And honestly, the same is true for the other factors we've considered today, for tobacco use disorder, for obesity, and for diabetes. What is reasonable for this patient to balance the risks of complications of surgery with the risks of leaving them with impaired mobility, risk for falls, and other things that can happen if they don't proceed with their joint arthroplasty. So in summary, hopefully we've achieved our goals. We have identified some modifiable metabolic risk factors for poor surgical outcomes, including death, diabetes, obesity, smoking, and malnutrition. I hope I've convinced you that we should avoid the term cleared for surgery, but instead talk about optimizing patients for surgery or balancing the risks and benefits. And then finally, I'd really like each one of you to, and I continue to think about this for myself, what is the threshold for an individual patient? I've listed some of mine here, and I'll be eager to hear your comments during the question time. What do you do for each of these diagnoses when you're trying to decide whether to go ahead with surgery or not? So thank you for the opportunity to talk to you today. Let me get my video back up. It's a pleasure to work with all of you, and I thank you very much for sending your patients to see me.
Paul, are you going to speak or?
No, I
wrap it up?
think this is,
Questions?
I think this is a good time to take questions. I felt like these guys did such a good job. I didn't really need to add to it, but I'm certainly happy to weigh in with my thoughts as questions come up.
Yeah, I would agree. That was wonderful. And for all of you throughout the department that don't know Dr. Mitchell, if you were having elective orthopedic surgery, you could not do better than having her as your physician.
That's very kind, Dr. Chansky. Thank you.
Well, I have a question. On one of the slides, I don't remember whether it was Dr. Wilkerson or Dr. Mitchell, there was a note made of the importance of checking blood glucose on post-operative day 1. And just, this huge push now to get our patients basically out of the hospital on the same day. This is for any of you actually. I know there's some early literature on this, but do you think this can be done safely as long as we have very strict triage criteria?
I can take that, Dr. Wilkerson, if you like.
Sounds great.
So the answer is, I think it can be done very safely for those who have those patients who have experience with insulin. They check their blood sugars at home and can dial up and dial down. We can give them very specific instructions. The trickier thing is for patients who either are diabetics who use only oral medications or people who have no history of diabetes, those folks, it's a little trickier to give, for example, long-acting insulin and then just send them home. And I, maybe I'm a little biased, but I think the literature is so clear that hyperglycemia, especially in the first 24 hours after surgery, improves our outcomes, that I think it's worth keeping patients to keep good glycemic control, because the risk is if you force them out the door, they're going to come back with these terrible complications, which are extremely costly. And so, I think that's even though I know you're feeling pressure to get people out the door, holding the line is important. And I think the data bear that out.
Yeah, thank you. One other maybe.
Oh, Howard, I have one comment about that.
Oh, go ahead, Dr. Fitz.
So, Jay, great talk. Dr. Mitchell, thank you very much. Really informative. That Antonia Chen out of Harvard, she's published on this. And it might be the one Dr. Wilkerson mentioned, but they even looked at post-op day 0, looking at their glucose, I think like 6 hours or 8 hours after surgery. And that was also a predictor of complications as well. So not that that's a reason to get people out early, but it's something that we should be even doing within 24 hours, make sure that they're maintaining tight glucose control, especially on these diabetics and people that kind of had tenuous control at the start. And I have seen a number of my patients with blood glucose is about 300 in the PACU when we're coming out of surgery. So it's not something that we should be worrying about post-op day 1. It should be something we're really worrying about post-op day 0 as well.
Apologies if I misspoke. I completely agree that the protocol at Northwest is, so let me back up. Another challenge that we have with managing blood sugar is that joint patients and many orthopedic patients eat right after surgery, unlike general surgery patients. So for general surgery, we often will start an insulin infusion and then just continue that, dialing up and dialing down after surgery to obtain really tight control. And you can't do that when people are eating, because you would suddenly be dialing way up and then putting patients at risk for hypoglycemia. And so the protocol we've developed that is similar to other institutions looks at blood sugar the morning of surgery, and then we give a long-acting basal insulin the morning of surgery, which allows a moderate level of control. The trick is we don't do that for people who are going home same day. We only do it for those folks who are sort of overnight obs, the 23-hour folks. But I agree with Dr. Fitz, those first few hours are really important.
So as we move, which we will have to at both campuses, to outpatient elective joint replacement surgery, we're just going to have to be very thoughtful about it, particularly with the population of patients that we tend to care for. I had one comment, and then I'll check to see if there are other questions. My personal bias is that our colleagues in medicine underestimate the significance of patients being on even low doses of immunosuppressants such as prednisone. And my sort of naive take on that is if it wasn't functioning at that low dose as an immunosuppressant, it wouldn't be doing anything and the patient wouldn't be needing it.
Right.
And I noticed on your slides, I thought it was really interesting, even at less than 5 milligrams per day, those are small risk of infections, but they're enormously higher than our baseline, 0.75%, risk in the first year.
Yes.
And so I think it's important that we really try to get patients on the absolute lowest doses of those as possible. I think the risk of infection and delayed wound healing is really underestimated. There is a question. I'm going to read it. It's from Dr. Clavino. And it says, Dr. Wilkerson mentioned payers are looking closely at readmissions and complications. Whether the disease is heart failure, trauma, or osteoarthritis, many of the sickest patients in the region are referred to UW medicine. So true. What is our role responsibility to care for these high-risk patients? and how best to communicate to payers that we are taking care of medically complex arthroplasty patients. And this should be valued. And Paul, Dr. Minner, I think that's a great question for you. And then Dr. Mitchell and Wilkerson, if they have anything to add.
Sure. So, so the short answer is, yes, we do get much sicker patients than the average. When you look at the CMI, which is comorbidity index, our average joint patient is, basically twice as sick as the average patient walking in off the street to our friends and neighbors in the community. The short answer is yes, this is our role. Yes, this is our responsibility. This is part of our job, and it's kind of like that's one of the reasons we're at an academic center is because it is our calling, if you will. And I don't want to get too maudlin about it, but this is part of our job. As far as getting paid more, that's a wonderful idea. There is the idea of a modifier that, you can ask for it. But the short answer is that, total knee replacements, the most expensive single line item in the CMS budget. They are not looking to pay us more. They are looking, if anything, to pay us less. So the short answer is we will get a nice pat on the back, but we're not going to get any extra cash for it. The short answer is that it is cost effective if we have people like Dr. Mitchell who can optimize the patients to the best of our abilities. Part of this is talking to the patient and letting them know that this problem is going to increase your risk of having a problem. And at a certain point, you have to kind of go, yeah, that's enough. You're diabetic, you're morbidly obese, and the answer is, not never. Not that we're never going to do your surgery, but we're not going to do your surgery now. And we're going to do the best we can to make you as fit as possible. Connor, does that kind of answer your question or questions?
Yeah, definitely. Obviously not a perfect answer out there. I just know that you've thought a lot about this, and you and I have talked about this in the past. And it's just, I think one of the challenges is to how to find that balance of, as you said, doing our calling, our responsibility for taking care of the sick people, but also, as Dr. Wilkerson said, doing it at the right time to optimize their outcomes and educating the stakeholders in the healthcare market about what responsibility we're taking on and what value that should be applied to it. Doesn't mean maybe surplus reimbursements to us, but maybe when the next round of cuts come through, as you said, that that maybe the cut is less for those taking care of the patients with a lot of medical comorbidities, and how we rely on people like Dr. Mitchell and a team-based approach to really optimize these outcomes.
Yeah, I mean, we had at one point had a little bit of pushback about the idea, well, why are you guys sending all these patients to, it was Dr. Lee and then Dr. Mitchell kind of in cohort, your outcomes are pretty good, the numbers are looking pretty good. Why are we spending all this money on this preoperative clinic? And the answer was, the reason the outcomes are good, okay, is because we have this pre-op clinic and because we are having them taking care of our sick patients. And if you took them away, things would get much, much worse very quickly. And then eventually it went away. Whoever was, had to be in their bonnet went and found something else to worry about. But, the point is that, services like a hospitalist service and like a preoperative optimization clinic are cost effective because they keep the disasters from happening.
May I offer a ray of hope? We've had recent movement in this area in internal medicine. Prior to January 1st of this year, when I would see a patient, so I have a triage criteria that I use because, the really well-controlled or diet controlled diabetics don't need to come here for every surgery. I see them for the joints, but and so I try to be careful about picking the patients that really need this service. And so they're all pretty sick, and similar to your 22 modifier, I used to have a prolonged services code I would add. And the problem was I would see the patient, add the prolonged service code, and then spend more time than that on every patient. And because of our UW tertiary referral population, and starting January 1st, the American College of Physicians lobbied for for CMS payments to reflect that. And now there's a modifier I can keep adding forever until all that time is paid. And it is lovely because you can only do it on that day of service. So it reflects accurately what I do. I spend a lot more time with a smaller number of patients, and I can bring savings to the institution by telling some patients, really, I don't think you should have, obviously it's the surgeon's decision, but I can say that this person really should not have this surgery now, and hopefully save costs that way. And then, as you're saying, we try to reduce complications in the hospital.
That's really good news. My follow-up question was going to be, maybe the better question is, should our colleagues in medicine be getting greater reimbursement for the financial and medical impact? Of course, CMS is budget neutral, so sadly that money has to come from someplace else. And to follow up on Connor's question, I think the other concern is that these patients clearly have higher readmission rates. And there are some studies, and I think it fits our gut feeling that, the case mix index does not accurately reflect how ill and how high risk some of these patients are. And our hospitals take a big hit, and our, quote unquote, reputations, now that this is publicly available information, take a hit. Because of these events that are never supposed to happen in the first, 30 to 90 days, after surgery. So it's a real big problem. I mean, Dr. Manor knows, we've really done some deep dives into seeing why some of our complication rates, such as readmissions or DVT, PEs, infections, were higher than the observed to expected ratio. And it's because these patients are so ill, and it's not reflected in any of our standard metrics, benchmarks.
Howard, to continue with that, also not only are these people sick, their social situations also impact this in terms of their people who can take care of them, resiliency, where they live, their proximity to healthcare and everything. So not only from just a medical complexity, they're also disposition and socially complex as well. Yeah. To continue with Dr. Mitchell's point is that it might be something that we need to lobby. This is not something that's exclusively happening at UW. It tends to be all these tertiary care centers. And not to rain on anybody's parade, but there's a recent paper out of Rothman, and they're in the bundle, which we aren't, but they looked at basically their complication rate, their reimbursement, and their margins over a 3-year period from 2015 to 2018. And they decreased complication risk, length of stay, decreased infection risk, length of stay, but had the same neutral complication risk. And yet through the bundle, their compensation decreased from about $25,000 total per total joint to $18,000 total joint, and their margin decreased from $2,500 per patient to $500 per patient. So they got better at doing the surgery. They did it safer and faster, and yet the reimbursement per patient, what they were able to make from it, went down by 500%. So it might be that we need the lobby, especially as you mentioned, CMS being budget neutral, that this might have to come from the government before we're going to really be able to address this, address the medical complexity of our patients.
Well, it's 7:45, and I know some of us have clinic and surgery. And I want to thank Dr. Wilkerson, Dr. Mitchell, and Dr. Manner. That was really wonderful. Jake, great introduction. I certainly learned a lot from this, and same with Dr. Mitchell's presentation. So thank you again, everybody. Have a great day.
Fantastic. Okay. Karen, Jake, thanks for a great job. Really, really well done.
Thanks, everybody.